Right. Hello, everyone. I welcome you all on behalf of IASNM Missy Radiant Flashpoint webinar series. This is a 45-minute session followed by 15-minute Q&A. And kindly please mute your phones and devices while the session is on. And you can put your questions in the chat box or you can answer at the end of the session. Now, it's my absolute pleasure and honor to introduce Dr. Ramya VC, who is a specialist in breast and endocrine surgery. She is currently practicing at AIIMS hospitals in Hyderabad, and she has been trained at most of the prestigious institutions at India like JIPMER, AIIMS, and SGPGI in Lucknow. And Dr. Ramya believes in multidisciplinary management of breast cancer patients. On a day-to-day basis, she closely works with allied departments like radiology, nuclear medicine, pathology, medicine, and radiation oncology. She has also published her work on the use of fluorescein in sentinel lymph node biopsy in early breast cancer patients in World Journal of Surgery. Dr. Ramya has also published a book chapter on hormone therapy in breast cancer, and she attends multiple international and national workshops on oncologic plastic breast surgery. I welcome Dr. Ramya. Dr. Ramya.
Thank you, ma'am, for that kind introduction. So I was just saying that it's rather bold of me to be talking to the nuclear physicians about role of nuclear medicine in the management of breast cancer and the current and the future. So I'll just start with this basics of breast cancer, not spending much time on this though. As we all know, the most common malignancy among women worldwide is breast cancer, including India. And breast cancer is not just a single disease. It has many subtypes, which are predominantly classified based on immunohistochemistry, which is done for estrogen receptor, progesterone receptor, HER2, that is human epidermal receptor 2, Ki67 or proliferation index. All these subtypes have treatment implications. So the aggressiveness correlates with the subtype of malignancy. But however, we have always known that for a given subtype also, there are individual variations. So it becomes important that we give tailored treatment and we have tailored mechanisms by which we are able to understand the exact prognosis or aggressiveness of a tumor. So as we all have heard, statistics are for statisticians, but for treating physicians, for individual patients, we need real data in that particular patients. That's where I think the nuclear medicine helps a lot, and there is a lot of scope for improvement and can help the clinicians who are managing these patients. And especially because we all know that breast cancer can have systemic spread quite early in the process of the disease, especially for triple negatives. So the treatment of breast cancer is also guided by the stage of the disease. And the current standard is to do multimodality management, including surgery, chemo, radiation, targeted or molecular therapy. And the latest kid on the block, which is very, very promising, is the peptide receptor radionuclide therapy. And it is imperative to have high quality, precise subtyping and staging tests for that reason. So here is where the nuclear functional imaging has extensive role in the diagnosis, staging, prognostication, and the treatment of breast cancer. So according to the NCCN guidelines, the use of functional imaging studies for evaluation of patients with primary breast cancers are optional unless directed by symptoms or abnormal laboratory tests. So currently, in early stages of breast cancer, it is basically a symptom-directed evaluation. And if there are symptoms, the recommendations are to do contrast-enhanced cross-sectional imaging, but there is, we have actually more in favor of whole body imaging, especially with the current available PET scans. So I have classified for the presentation's sake the application of nuclear medicine in the management of breast cancer in terms of diagnosis, staging, treatment, and the future possibilities. Of course, I've stretched my imagination in the future possibilities. So first, coming to diagnosis, diagnostics are still under development in as far as nuclear medicine is concerned. It's mostly corroborative evidence. And the one that we know of in diagnostics is a CT mammography. The overall sensitivity of CT mammography is about 85.2%, and the specificity is close to 87%. And it is more for patients who have palpable mass versus who do not have one. So the results from various studies, especially from this meta-analysis, have shown that as of today, the CT mammography can only be used as an adjunct to the routine X-ray mammography, but it cannot be a standalone test for diagnosis. And coming to the staging of breast cancer, that is where I think the maximum progress has been made as far as the nuclear medicine is concerned. I'll start with this, the bone metastasis in breast cancer. Bones are common site for metastasis in these type in breast cancer, and the common sites include spine, long bones, pelvis, ribs, and skull. And the most common symptom being pain. And these metastases can increase the risk of pathological fractures, can cause poor quality of life and disability. But one has to understand here that even though patients who may have metastatic disease, that is stage 4, many of these patients with bone metastasis survive for years. So it's important that we give good quality of life for these patients. So it is important that we have adequate assessment of the kind of tumor that has spread, what is the variability, heterogeneity of this tumor, and what are the possibilities that we have to treat these patients. So as I was just mentioning, the evaluation for bone metastasis is indicated currently, not routinely done, but especially in early stage 2, it has to be done if there is a clinical suspicion or increased biochemical markers. Whereas in locally advanced disease or in inflammatory breast cancer, we can do it upfront. So there are a lot of ways with which we can identify bone metastasis, starting from simple plain X-rays, going to bone scintigraphy, CT scans, MRIs, and the positron emission tomography scans, and the PET CTs. So the classical tests have been bone scintigraphy using technetium, radioactive technetium labeled tracers like MDP, and which can, when combined with SPECT CT, can give good spatial resolution and understanding as well. So the basic principle of bone scintigraphy is thus the accumulation of these technetium labeled phosphonates, which are affinity for hydroxyapatite in the areas of bone formation. So this technetium 99M is a gamma emitter, and 18 fluoride sodium fluoride is a positron emitter. This is one of the earliest ones that was used in assessing the bone metastasis. But the mechanism is similar to technetium MDP, and it goes to the areas of bone remodeling. During bone remodeling, because of osteolytic or osteoblastic process, the hydroxyapatite is exposed, and this goes and gets attached to this hydroxyapatite and gets incorporated into the bone matrix. That is where we can visualize this. But because of easy availability and comprehensive assessment of bone and soft tissues with newer molecules, the role of 18 fluoride, sodium fluoride, has become limited in the current scenario. So a meta-analysis has shown that the PET CT, the FDG PET CT, has higher sensitivity and accuracy for detection of bone metastasis in breast cancer compared to bone scintigraphy. And also we can understand that there is an added advantage of detecting other organ involvement, not just bones in these patients, because once there is metastasis in one organ, there is a high likelihood that they have mets in other organs as well. So coming to detection of multi-organ spread, moving on from bone-only disease, moving on to multi-organ spread. So this is where the most commonly used happening PET scan comes into picture. So in patients with solid tumors, imaging modalities that provide morphological and functional data become invaluable. So PET is a widely utilized such functional imaging modality, and among the molecular imaging technologies, PET has the advantage of offering very high sensitivity compared to, say, a gamma camera and gamma scintigraphy, and it can be combined with a CT scan and an MRI. It can give relatively better spatial resolution, improving the detection and quantification of the regional tracer uptake as well using SUV. So the 18-fluoro-deoxyglucose tracer is the most common tracer used for PET scan. And the principle, as we all know, that the fast multiplying cells are starving for glucose. They use more glucose for their proliferation. And that is where this gets incorporated, competing with the body glucose, and starts emitting the positrons, which are captured by the PET scanner. So FDG PET CT is the most common PET performed in breast cancer patients as well. So when we see normal breast, as we can see in this image, there is one abnormal focus and there's a normal breast. Even the normal breast has mild uptake. It can vary with physiological state of the breast, and it's generally mild in normal and marked in lactating breast. So FDG PET earlier was thought that is most clinically useful in staging especially recurrent or metastatic breast cancer. But the upcoming studies, and in my personal opinion, it is very useful even in evaluating a new newly diagnosed patient of breast cancer. So it's also helpful in assessing the response of locally advanced disease for chemotherapy or completion of treatment. And in my view, PET CT for staging can replace doing a host of tests like a CT chest, abdomen, bone scan, all that. We can do a PET, FDG PET in most cases and get a reasonable comparable information. So the consensus statement now says that FDG PET is optional and is most helpful in situations where standard imaging results are suspicious. So they have mentioned that routine use of FDG PET is not recommended in early stage 1 and 2 or operable stage 3 breast cancers, because there seems to be high false negativity rate for small lesions for low-grade disease and high false positivity rate in patients without locally advanced disease. And there is comparatively low sensitivity for detection of axillary node mets compared to, say, standard mammographic or ultrasound evaluation, and of course guided by pathological test. And there is low pre-test probability of these patients anyways to have detectable metastatic disease. So the current possible indications as per these guidelines for FDG PET are stage 3A and beyond, inflammatory breast cancer for sure, because of increased risk of regional lymph node involvement and distant spread, for loco-regional recurrences, for suspected systemic mets, and for patients who, as we were just discussing, who have suspicious features or equivocal results on other tests. So, but one has to remember that uptake on FDG doesn't mean that it is a proven metastasis. It has to be confirmed with a pathological test. Of course, it's not possible to biopsy every lesion. We select some most probable lesions and biopsy them. But with increasing combination of good resolution CT scans with PET, earlier it was thought that the PET CT, the CT resolution is poor and it may not really help to pick up small ones unless it is having good activity. But nowadays it's possible to combine good resolution CT scans with PET, and it is increasing the role of PET scans in breast cancer patients. So, so if we have detected bone metastasis on FDG PET, it is not needed to do again bone scintigraphy. So apart from the FDG PET, as we were just discussing, there are newer PET tracers that have been developed. One such is an estradiol labeled with 18-fluorine, which is FES PET CT imaging, and it is used in the detection of in vivo estrogen receptor expression. So the estrogen receptor expression in the biopsy may just be a representative one, but exactly it's not possible to biopsy every lesion of metastasis. So when we are able to do some non-invasive imaging like this one, it is possible to understand the heterogeneity of ER expression, and it can guide us whether we have to be aggressive in treating the ER targeted therapy or not, or is it like what is the general distribution of ER expression. So 18FES has been recently approved by FDA, and NCCN recommends to use it in ER positive metastatic disease if possible, if needed. And they have this scan has high specificity and sensitivity for ER expressing lesions, and it can predict patient response to hormonal therapy. And it actually guides us in optimizing the patients who have ER positive metastatic lesions by giving an estimate of the heterogeneity. And especially in invasive lobular carcinoma, it has better sensitivity for bone lesion detection compared to a FDG PET, because these lesions are growing slowly and they may not take up as much as glucose, but the ER expression is robust in these lesions. And so FES can have greater role in detection of bone lesions, especially in invasive lobular carcinoma. And one disadvantage with this is that it is metabolized by the liver, so it complicates its applicability for detecting liver metastasis. And if we are suspecting liver mets, it's better to go for cross-sectional imaging if it has already been evaluated with the FES PET-CT. So the other promising tracer is a fibroblast-associated protein inhibitor labeled with 68 gallium, which is called as FAPI PET-CT. And many cancers, including breast cancer, overexpress fibroblast activation protein. So this protein, particular protein, contributes to migration and tumor neovascularization. So it's a serine protease which functions in tumor stroma, and it is highly specific and sensitive for the detection of many cancers. Inhibitor targeting this FAP, that is FAP inhibitor, PET-CT, guided PET-CT, is a new radiotracer targeting this particular protein to visualize the tumor stroma and detect metastasis. So the quinoline-based PET tracers that act as FAP inhibitors are considered to be superior to FDG in detecting more lesions and showing tumor activity. Basically, the sensitivity is so high that it can show a shower of lesions which may not otherwise be detected by FDG. And in fact, the FAPI has higher SUVs than FDG for the lesions located in the breast, local or distant lymph node metastasis, liver, lung, and bone. So it is seen to accurately depict primary or metastatic lesions in various organs because of its high target to background ratios and good tumor delineation. In tumors less than 1 centimeter, it demonstrates higher uptake, and therefore it has ability to show a lot of lesions, which I was just saying FDG cannot be able to show. So, however, histopathological confirmation has shown that the specificity is slightly less compared to FDG, which is true for all those tests which have very high sensitivity. So, I mean, most of the tests which have very high sensitivity, they may have a slightly lower specificity because they tend to detect a lot of those lesions, which may not be sometimes be able to be confirmed with the standard protocols. And another advantage of the FAPI imaging PET-CT is that there is no need to diet or fasting because the sugar levels need not be controlled, and the preparation time is not necessary. And the image acquisition can be started within few minutes after giving the tracer. So it is a promising agent. And the other one that is underway of development is a zirconium labeled trastuzumab HER2 PET imaging. HER2 positive tumors contribute about 20% of the breast cancers which have amplified expression of human epidermal growth factor 2. So they are more aggressive than HER2 negative tumors. That means HER2 positivity is more aggressive compared to HER2-neu, but thankfully we have some specific anti-HER2 molecules like trastuzumab and pertuzumab. So PET using targeting this HER2 molecule can visualize the heterogeneity of HER2 expression, like we were just discussing for the ER, and it can help us and guide us in further managing these patients. So zirconium and copper labeled trastuzumab PET-CTs are being evaluated in identifying these patients. And the main disadvantage of this antibody, radio-labeled antibody, is that the scan can only be done few days after the tracer injection. There are some nanomolecules which are underway of development. And this area is basically a fast growing area, and a lot of work is going on in this zone. So not only these, we have many more options that can act as potential targets for molecular imaging. like, especially in breast cancer, like the steroid receptor expressions, which are yet to be explored, are progesterone receptor, androgen receptor, and cell proliferation markers like thymidine analogs, amino acid transporters, and PARP overexpression can also be cached to devise new molecules. In fact, some of them are already under evaluation, like I've mentioned in this table. So these are all potential possibilities. So coming to another development which has increased the interest of breast surgeons in managing breast cancer is a PET MRI breast. So MRI has the advantage of being very sensitive, and we can evaluate both the breasts simultaneously. Not only that, we can get physiological parameters from MRI using various sequences, like, for example, for tumor neogenesis using a dynamic contrast enhanced sequence, for cellularity using diffusion weighted imaging, and application of these pharmacokinetic sequences, perfusion parameters. We can extract all this and we can have an idea about the tumor vascularity, how the surrounding interstitium is, and it helps us indirectly. Maybe if we do a little more focused work on in these areas, it can help us to understand much more, like including tumor aggressiveness, and it can even help us to assess and monitor response to systemic treatment. So cancer has various hallmarks like angiogenesis, activating mutations that help in invasion and metastasis. They evade growth suppressors. They enable replicative immortality, like they have uncontrolled growth cycles and they're able to survive and resisting cell death. So the mechanisms by which the cancer cells are able to survive are also the targets by which we can detect them. So breast PET MRI has potential hybrid imaging and targeted tracers in all these avenues. So it is now possible, it now has been possible to combine these two modalities because of change in the bringing up compatible devices. Because as we earlier know, MRI compatibility with various devices was restricted, but now MRI compatibility with many things has been improved by using various combinations of materials. And so hybrid PET MRI thus allows to simultaneously collect morphological, functional, and metabolic information. And not only that, we can even turn the patient around, because breast MRI is done in prone position. We can turn the patient around in the same examination and acquire a PET whole body imaging to get highly sensitive information on systemic spread as well. So it's very promising. So coming to digital PET scans. So we are all fans of digital. We no longer like analog. Similarly, even PET scans have become digital thanks to the small silicon photomultipliers. They are able to provide good higher spatial resolution, and 100% coverage of crystal area has made this possible. There is high sensitivity, low noise, and fast timing and good resolution. So with optimized acquisition and reconstruction protocols, it can improve the localization of the annihilation events and provide high definition images, and thus has higher diagnostic performance. So digital PET thus can help quantify and characterize even the small lesions which are not able to be detected by analog PET systems. Thus, digital PET offers, because of the fast acquisition, offers the possibility to reduce the radiation dose and, of course, the scan times. So that's about the staging. Now coming to the most important aspect for a surgeon, which is a sentinel lymph node biopsy and lymphoscintigraphy. So lymphoscintigraphy is not routinely used. It is done using a gamma camera. These days we have portable cameras, and preoperative tracer injection and scanning the axillary area for possible spread into, identifying the location of the nodes, or sometimes we can add SPECT CT to localize these areas. But it is only helpful in certain situations, like if there has been a previous axillary surgery or extensive surgery in the breast, which we are expecting that would have altered the normal lymphatic drainage. Only in those cases we would like to do preoperative lymphoscintigraphy these days. Routine use is not recommended, but it's a very, very helpful method. So coming to the actual sentinel lymph node biopsy. Axillary lymph nodal status is one of the most important parameter that has prognostic value in the outcomes of patients with breast cancer. So it guides treatment, and whenever there is clinically negative axilla N0 disease by palpation and preoperative imaging, the pathological node positivity rate decreases to about 18%. In such patients, doing SLNB is the standard of care. No longer, we need not do axillary dissection. This has been the standard of care for many years now, and we're all familiar with this. So it is indicated in patients who have N0 disease in early breast cancer and in ductal carcinoma in situ patients who are undergoing mastectomy, where we lose the opportunity to do SLNB later. And many people think that multicentric disease is a contraindication. It is not so. We can do SLNB in patients with multicentric disease. However, the absolute contraindications for SLNB are clinically positive nodes, then there's no point in doing SLNB. And in patients who have locally advanced tumor, especially 4A to C lesions or inflammatory breast cancer, because there is a high chance of false negativity rate because of blocked lymphatics. The very principle of SLNB is defeated in these patients. And we have to keep in mind that recurrent breast cancer and previous axillary surgeries also, the false negativity rate is high. So studies have shown that the breast lymphatic drainage from all quadrants goes to the same group of level 1 lymph nodes. The sentinel lymph nodes are generally located in the level 1 or maybe early level 2 for any quadrant of the breast. That actually helps us to gives us more confidence to do SLNB without changing the practice for a certain location of the tumor. So all the sentinel nodes draining the breast can be located variably. They are usually found within the level 1 or lower axilla. So subareolar or intradermal injection of the dyes or tracers makes it's SLNB feasible, especially in patients with multicentric disease. There are some special situations like pregnancy. SLNB is generally avoided because we do not have the data on teratogenic effects of blue dyes, as well as lack of safety for radioactive tracers. And in such patients, we have other options like low axillary sampling. We know that there are the nodes in level 1 are the ones that are first echelon nodes or sentinel nodes. We can just sample them in such patients. And non-axillary lymph node biopsy, that is internal mammary nodes, is not a standard, but though it is visualized in 20% patients during scintigraphy, but it is difficult technically to remove these nodes, and there is no consensus. There's no guideline to excise internal mammary nodes if they're seen on SLNB. But we do have radiation therapy that is given to internal mammary chain to handle if there are any metastases in such patients. So as we can see in this picture, is the blue lymphatic entering into a blue lymph node. This is the gamma probe, and this is the gamma camera. So more in a bit. So the best site of injection, basically the SLNB can be performed using a dual tracer or single tracer. I'm coming to that in a bit. The best site of injection is debatable. It can be done peritumoral, intradermal, or subareolar plexus. Intradermal injection appears to be superior to subdermal injection. So because especially injection into dermis and subareolar areas, retroareolar injection is seen to have less internal mammary node visualization, which we don't want actually. So we can use filtered and unfiltered colloid agents to inject for these patients. And unfiltered molecules are large, so they are tracked better in lymph nodes, whereas filtered ones are small and they can help in quickly identifying the lymph nodes for lymphoscintigraphy. So preoperatively for scintigraphy, if we give both filtered unfiltered component, then it's possible to do both the procedures, and we can select depending on the situation. So the amount thus injected is based on at what time we are injecting. Suppose if we are injecting in the previous night, we have to give more dose, and if we are injecting on the day of surgery, less dose. And following injection, a breast massage is done, and a handheld gamma probe is used to identify the maximum radioactivity in the axilla. So the SLN starts being detected as beginning 10 to 30 minutes after injection in most filtered tracers. So we generally give incision over the hot spot, and we follow the 10% rule. Then we identify all the blue nodes, palpable nodes, and then send them for frozen section. If they're positive, we complete the axillary dissection. If they're negative, we leave it as such. So there's something called as the shine-through phenomenon, where tumors in the upper outer quadrant or axillary tail, the gamma probe fails to isolate this from the sentinel node signals. There we can use a collimator to focus our, to just detect the activity in that particular region. So other solutions for such tumor locations are to use subareolar injection, because it's far from the axilla. And suppose if we've accidentally injected, then we should proceed with tumor resection and then do the SLNB after the removal of the tumor. So other traces like ICGs, PO, magnetic tracers with handheld magnetometer, carbon nanoparticles, microbial contrastant fluorescent are also being evaluated. And ICG is almost pretty much confirmed to be a good tracer. So coming to whether dual dye or single dye technique is superior, the studies have shown that dual technique has much lesser false negative results, and it is the standard of care. But if suppose a facility doesn't have a radio tracer, then a single dye technique is possible to be done in experienced hands, depending on the clinical situation. But it is always recommended to do a dual dye technique. Coming to the radiopharmaceuticals used for SLNB, the commonly used ones are sulfur colloid, and the latest one is a bioengineered molecule called tilmanocept. The only advantage of this bioengineered molecule is that it's a mannose derivative, and the pain at the injection site is less, and it is selectively and robustly trapped in the lymph nodes, macrophages. So it is an effective tracer, which is developed specifically for this purpose. And all of them use technetium-99m, which has about half-life of about 6 hours. So sulfur colloids and tilmanocept have been approved. And antimony colloid is also been used in certain developing countries. So now coming to radionuclide therapy, coming to treatment part. So bone metastasis again is one area where radionuclide therapy is very, very helpful. It is seen, bone mets are seen in about 70% of patients with advanced breast cancer. It causes significant pain and skeletal events like pathological fractures, spinal cord compression, and hypercalcemia. So decreased quality of life is seen for these patients, and it reduces overall survival. So bone-only metastases are seen in about 17 to 37% of these women. They can be osteolytic, sclerotic, or mixed. But it could be simultaneously seen, both the process could be simultaneously seen in a given lesion. So only in case of bone targeting radiopharmaceuticals, it's important to understand whether they are bone forming, that is sclerotic or osteolytic metastasis, because the treatment depends on certain, mostly given in osteoblastic lesions. So there are a lot of treatment options, and one of them is using bisphosphonates, analysis, starting from analytics, chemotherapy, bisphosphonates, and the latest is a radionuclide therapy. Of course, there could be focused external radiation, and sometimes surgery is also indicated. So each treatment modality has specific indications, advantages, and disadvantages. So most are beta emitters. The particulate radiations are beta emitters, and some of them, like especially the radium, has alpha emitter. The difference is that beta particle low energy, longer range of penetration, a lot of dispersion of activity and side effects, whereas alpha emitters have high energy, short range, so that's high tumoricidal activity and less radiation damage to the adjacent tissue, targeting only the area affected. So, but most of the traces that we have are beta emitters, and they can help in radiating a large area, thus are helpful for bone pain palliation in a large area of involvement, whereas alpha emitters can be used in getting the tumor regressed and can help increase survival. So requirements for optimal bone targeting pharmaceuticals, they should be selective uptake and prolonged retention in the metastatic bones. There should be rapid clearance from other sites. There should be good biodistribution, and that can be estimated by imaging modalities. Simple process to produce, use, and it should be cost effective, low toxicity. I mean, in an ideal world, we want all this. So it should be clinically proven to be effective. So there are some bone-targeted radioisotopes. Multiple bone metastasis cause diffuse pain, which is not easily managed by focal radiation. but we can give hemibody radiation, bone-targeted radioisotopes, especially the beta-emitting ones like the strontium, samarium especially, are very good, and alpha-emitting radium are under trials, and thus they seem to be more effective. So coming to the standard samarium therapy, samarium ADTMP, bones tend to have more metastasis because of the vascularity and the microenvironment that favors. And samarium linked to bisphosphonates gets again trapped in this bone forming areas and emits both alpha and beta and alpha particles, and we can the gamma particles. We can image using the gamma particles, and the alpha rays can give the treatment part of it also. So samarium therapy has been studied very well, and it is shown to be effective. And it can be used as an outpatient, which has shown to decrease significantly the effect on bone pain, and has shown to decrease analgesic consumption in these patients. So there is no other area of localization for samarium EDTMP other than bone, and is excreted mainly via urine. The pain relief starts from within a week, and it can last up to few weeks to months. So it has a good dose response relationship compared to 32 phosphorus chelated tracers. There is a transient but reversible myelosuppression, and it has been shown to be effective in phase 2 and 3 clinical trials. So it is approved for relief of pain in these patients who have osteoblastic metastatic disease, confirmed by a scan. 32 phosphorus orthophosphate is no longer used because of its severe adverse permanent side effects like severe hematological, to an extent reversible, but severe side effects like hematological toxicity, acute leukemias, and polycythemia vera. So, but however, it is effective, and maybe some modifications might help the outcomes. So this is just a summarization of the bone targeted therapy using where radioisotopes can be helpful. So coming to radium-223 dichloride, this emits alpha particles, as I was just mentioning. It is under investigation for management of bone metastasis. It delivers intense, highly localized radiation to the affected bone surface while delivering substantially less radiation to the healthy areas. In a phase 2 study of prostate cancer, it has shown to be effective, decreased pain, decreased skeletal related events, and bone specific ALP concentrations. So it is still under investigation in breast cancer. In another phase 3 trial also, it has shown to increase overall survival. That is actually a very, very important point for prostate cancer. And similar studies are underway even in breast cancer. So in a recent trial, they recruited breast cancer patients with bone mets who are no longer responding to endocrine therapy, who are ER positive. And they have the data has shown that the radium-223 tracer is well tolerated and reduces the level of bone turnover markers, and it has shown to decrease skeletal related events also. So this study has also shown that with the radium-223 treatment, there is decrease in uptake of FTG in these lesions as well. But more studies are ongoing. Now, coming to the future avenues of PET-CT or in general for nuclear medicine, it is important to understand that there are much more molecules that we can target, and we can make the tracers. So we wish that someday there are tracers. Suppose we have an ER/PR positive HER2 negative tumor with certain Ki67, we are able to use a particular molecule to image these patients. So combination of molecules and tracers to tailor-made a particular patient's tumor biology. Or we also wish that there are non-invasive methods by which we're able to, like how we are classifying tumors based on IHC, immunohistochemistry. We wish that on someday we are able to classify tumors based on nuclear imaging modality, where we are able to tell if it is this tracer uptake, it is aggressive. If it is not, then it is not aggressive, something like that. So we wish that there are tests to indicate the grade of the tumor at distant site, like how Ki67 helps. Of course, FDG SUVs can partially give the quantification, but we need more robust methods. So there are more and more targets that we are seeing these days, which are monoclonal antibodies, immunotherapy, and there are so many targets to develop protein molecules. So when there are protein molecules, it's also possible to tag them with the radionuclides, and they even can provide a neoadjuvant treatment options. So some such molecules are PARP inhibitors, especially in PRC mutated patients, CDK4/6 inhibitors, and we can even develop our own synthetic bioengineered molecules, and theranostics, which is diagnostics and therapy with the same, like for example, if there is MDP uptake, we can use samarium therapy, and in neuroendocrine tumors, we can even use lutetium therapy if there is a dotatate uptake, something like that. So targeting similar receptors. So that is also a future possibility. So many molecules and targets are there for development, and these are yet to be explored. So I took this table from NCCN guidelines. We have FDA approved agents. These are all the proteins to which we can attach, combine the radioactive nuclides, and they can help in diagnosis and treatment as well. So like there are various types of breast cancer, and there is a lot of variability in Ki67 that should be able to be correlated with imaging, and we should be able to understand the tumor proliferation rate, and we should make tailor-made targets for these patients. We should have a targeted therapy like radioactive iodine for say a thyroid cancer, and neoadjuvant targeted therapy is also possible using this. So with this stretching of imagination and hope, I end my presentation. I'll be very happy to discuss, clarify, take feedback from you all. Thank you.
Thank you, Dr. Ramya. Excellent presentation. And now I'll open the floor for questions. I think, Ishani, do you have a question?
Yes, thank you very much for excellent talk. I just want to ask, where do you see basically limited role by nuclear medicine physician? What you are looking for when you read our report? What exactly you want us to be more specific, or where you see utility can be, like all of us are using all the matrices and everything, but where do you see where we can make an improvement?
Yeah. So I think, I'll begin with the FDG PET scan, which we commonly use. So for example, I had a patient who has early breast cancer, a male patient with T2 lesion in the breast. So with N0 disease, and this patient had already come to us with an FDG PET scan, which showed a uptake in liver, a lesion in the liver. So now then, but there was no, on the CT, which was performed with PET, we were not able to visualize any lesion in that area. Then we went ahead and did ultrasound scan. Then we repeated CT, but we could not find any lesion in this patient. So now we are in a diagnostic dilemma, whether this is a systemic disease, because for the profile of the patient, the tumor that this patient has, it is clinically, I'm thinking that without axillary lymph nodes, it is not so common for it to just go into one lesion in the liver. So if that is not a metastatic lesion, at least there should be an inflammation. I mean, even that is not visible for me in this patient on a CT. So I think the specificity is a bit of a problem sometimes with FDG. And so coming to the newer advances, again, the resolution can be better. Instead of doing 2 scans, of course, now in our center, we recently installed a better resolution CT along with PET. So we are able to just do a PET CT and then FDG PET CT or a dotatate PET CT, and then use our the same CT scan for anatomical delineation. So yeah, I think I can think of these things.
Second question is for lymphoscintigraphy.
Ishani, can I interrupt and add to the discussion for this, because I think that was important, that we need to be a little more clinically relevant when we give our reports. So we just mentioned the hotspots and say cannot exclude metastatic disease, and I think that ties the hands of our referring physicians. Now that there's a report, And if they ignore it, and if it comes out to be metastatic, then they're liable. But if a majority of them are going to be negative, then they basically are required to follow up and prove that it is negative. That wastes time and resources, and sometimes they have to do invasive sampling, and that can cause problems to the patients as well, because they have side effects, like especially if you have a lung nodule that needs to be biopsied. If you do a CT guided biopsy, then there may be pneumothorax that may require a chest tube placement, and those kinds of things. At the same time, it also delays care in this patient, which right now, if the liver lesion is negative, is very early stage and has definitive treatment options for that patient. So I think the onus is on us nuclear medicine physiologists, physicians and radiologists to actually put those things in our report, that we need to know a little more about the clinical scenario of the scan we're interpreting, and the likelihood of patient having liver mets without, it's a small primary, no obvious nodal disease, and nothing in the mediastinum or lungs, and it's directly going to the liver. So at least at Emory, when we get such outside referrals, the general rule is we get a second opinion. So if the scan is done outside, they ask the Emory radiologist to give a second opinion on it, and then it also gets discussed at tumor board, multidisciplinary tumor board, and then we come to a consensus. And lots of times, when you put the whole thing in a better perspective picture, lots of times we can obviate the need for additional evaluation. We either agree that no, this is more likely to be a MET, or high chances given the risk factors, if there are aggressive histology or some weird, like if it's a triple negative disease or something like that, versus ER/PR positive low grade lesion, the chances of that being a true liver met is low. And then sometimes instead of a contrast enhanced CT, MR may be better for those kinds of things. Because you're right, like when you see a lesion on PET which is not seen anatomically, and you are asking somebody to biopsy, what are they going to biopsy? PET CT guided biopsies are extremely rare. There are very few institutions, at least in the US, that do PET CT guided biopsies. So most of the time they basically say we can't biopsy, and then the onus is left again on the referring physician to decide what to do, consider true negative or true positive. So I think this is a very good case that you brought up. And we need to be cognizant of these things when we read our reports, and start putting cannot exclude metastatic disease in every hotspot that we find. So I think we have to be a little more, we have to stick our necks a little bit and give chances that the likelihood of this being met is lower. At least that kind of helps. I favor this to be more likely to be, inflammatory or infectious or unrelated to the breast cancer, something like that would help making the decision. So sorry, and I think Maitri Shankar has her hand up. So
I think Maitri Shankar has her hand up. Yeah, please go ahead.
Yeah, hi. Yeah, I totally agree with the previous speaker. I couldn't figure out the name. What we do, I'm based out of, I was practicing in the US, now I'm based out of Bangalore, Aster Hospitals. And what we routinely do is, because in certain cancers like lymphoma, a hypermetabolic spot in the spleen or the liver can upgrade the staging. And if we are seeing a hot spot in the liver with no corresponding CT image, routinely we say likely benign, MRI correlation recommended, and we leave it a judgment call to the ordering physician. So both of us are covered, that we didn't miss anything, and they would probably keep a close eye on LFTs or perhaps follow up in post chemo, or that kind of a thing. My question was on staging. From what I understand, when we do TNM staging with the PET CT scan, how important or the decision-making points for a surgeon would be a PN2A. If it is more than that, if internal mammary is involved, that would be kind of surgical. You would probably still need either RT or chemo. higher than that, what are your cutoffs? Like, where exactly would the management change? It would, if it is locally advanced or lymph nodal staging, how can we better report in our reports, if level 1, level 2, level 3 kind of nodes? What are the top 3 or 4 things you would look for? That's something I would like to know.
The treatment plan basically depends upon 2 important things. Number 1 is the subtype, and as well as the number 2 is the stage of malignancy. So even a 0.5, more than a 0.5 centimeter triple negative breast cancer, we are now, we know that there's a role for chemotherapy, either neoadjuvant or adjuvant in these patients. So in these patients, stage doesn't matter. We definitely give chemotherapy because we know that these get dislodged and go quickly into the distant areas. And so as far as the other subtypes are concerned, if it is it also depends upon the volume of the tumor. For example, there's a small breast, a big tumor, then we prefer to give neoadjuvant chemotherapy, downsize it, and then operate. Or if there is a large breast, a relatively same size that we were talking about just in the previous case, then we can go ahead with surgery. So for as far as lymph nodes are concerned, if there are mobile 1 or 2 lymph nodes, we even can do upfront surgery. And we are able to most of the times make out the level of the lymph nodes by the mammography and the ultrasound as well, depending on the location of the tumor. If there are matted lymph nodes, I mean, if there is a lymph node of say 2.5 centimeter, it is generally thought that once one lymph node cannot become 2.5 centimeters, it has 2 or 3 have gone together. These are matted lymph nodes. So that way, I think also the location related to the axillary artery is how we classify the level of lymph node. And we generally prefer to go 1 echelon higher for resection. So yes, it is important to see if there are any lymph nodes beyond the in the level 3 or say in the supraclavicular area. So many times we see in the report that there are non-specific lymph nodal disease in the mediastinum and cervical lymph nodes. So that when I see that sentence, there are axillary lymph nodes with significant FDG uptake, say SUV more than 3.5, but there are also non-FDG avid enlarged lymph nodes in the neck and in the mediastinum. That sentence kind of puts us in, some sort of a discomfort zone. So in these patients, we probably be more err on the side of treating them more. So as far as distant spread is concerned, of course, we are thankful to the FDG test if we are able to detect FDG mets in these patients, which we would have otherwise not known. Because if we just go by NCCN guidelines, in early breast cancers, not do metastatic workup if there is no suspicion. But many times it just turns out, and medically it becomes important because the statistics again are just for statisticians. For this particular patient, the patient will come back and question us, like, why did the doctor, there is a FDG PET, why did you not do it? But if we are doing, we have to keep all these things in mind. I think in reporting, I mean, I'm thankful to my nuclear physician. I'm sure most of you will also give a description also, like say non-FDG uptake in that particular area, likely infective, or say in a bone, likely previous fracture, or say likely a degenerative disease. So most of the times we get clue and we easily pick up the phone and discuss. And most of the time with discussion, we get an impression whether, we get what they're actually thinking. They say, Dr. Ramya, I'm thinking more in favor of a metastasis. Dr. Ramya, no, I'm thinking it's most likely a degenerative process. So I think a lot of information can just be got with a good discussion with the nuclear physician.
Thank you, Ramya.
Sure.
It's important.
Thank you.
And yeah, exactly, and that's, as Dr. Takalkar very rightly mentioned, sometimes these, these enigmatic cases are brought into tumor board. Even picking up the phone and talking to the imager, or the imager picking up the phone and talking to the referring provider sometimes sorts out a lot of things, because sometimes what we put in the reports is like, what is the ordering provider? How is the ordering provider comprehending it? Like, is the ordering provider getting the feel what we are trying to communicate to, so that's very important. Ramya, I have a question for you. Do you have any experience with the molecular breast-specific imaging like system EB?
Actually, while I was training, I have seen some such descriptions of using system EB and SPECT CT in breast. In fact, I have a very interesting, I remember a case where we had done, I'm not sure if it's system EB, but yes, I have in the past, they had done some scans and I have seen, but I don't have experience doing limb scintigraphy in breast diagnostics. But I do remember a patient who had an infective etiology, filariasis of the breast. So this lady had come to us with unilateral breast edema. So she would have seeping from the breast. The skin is thickened, there is puriorange, and she has some low volume axillary lymph nodes. In this particular patient, actually, the lymph scintigraphy was done, and then we had detected that there was blockage of lymphatics and this particular pattern of the lymphatics. And then it was also complemented with ultrasound. We saw dead worm in the breast, and then she in fact did respond to the treatment DEC. So very interesting. I mean, while discussing in one of our presentations, nuclear physician came up with this idea, and then we did scintigraphy, and we could prove that there was blockage of lymphatics in this patient. So I wish I can share it with all of you sometime. So that was a very interesting case that I remember, but I don't have practical experience using system EB scintigraphy in breast. So we routinely do 3D mammography.
Okay. And Dr. Ramya, wonderful presentation.
Thank you, ma'am.
I have one question, might sound a little basic, but many times when patients come for staging, we see mild uptake in axillary nodes on ipsilateral and contralateral sides. So is it always good to report it? What is done in these cases? I mean, it's always a quandary, like, do you mention it and how significant are they? What,
yes, ma'am.
as a surgeon?
Yeah, I think, ma'am, that's actually a very clinically very relevant point. We see this many times. So luckily for us, axillary lymph nodes are accessible. And if we have some suspicion, we can easily do ultrasound guided biopsy or an FNAC at least and prove or disprove the same. So if in general, what happens in my experience is that the ipsilateral, even if it is positive or negative, the contralateral are generally not positive. They are generally just inflammatory nodes. It also depends many times after a core biopsy. Suppose the patient undergoes a PET scan, they of course undergo after core biopsy. There is some inflammation in the ipsilateral axilla after a biopsy because that draining area is also draining to those lymph nodes. So even that can probably increase mild FDG uptake. It's not a metastasis, but it is post-biopsy reactionary change that can happen in ipsilateral breast. And as we all know that there is a cross communication of lymphatics between both the breasts and across the sternum. So it is always good to report them, but with the caveat that the site, we can actually look at the morphology of the lymph nodes on mammography and ultrasound, whether the fatty hilum is retained, whether there's increased cortical thickness, whether they're rounded, are they big, matted. I mean, a lot of information can help us, but it's always good to be aware of them and evaluate further than missing and getting to know them only later.
Sounds good, Ramya. I think Ishani had a question, and there is will take Pushpa.
Yeah, I think Ishani had a question about sentinel node before I interrupted her.
So let's take Ishani first, and then we'll take Pushpa before we conclude this session. Ishani?
Well, I think she dropped off. I don't see her.
Okay. Pushpa?
Hello, Dr. Ramya, excellent presentation. Nicely you have elaborated. One small, this one, like whenever we see a non-FDJ with small lung nodules, tiny lung nodules, always we get a call. How you take it significantly, like clinically, how you go ahead, like do you take it like in your experience? Like,
yes, ma'am. what I would do is I would look at the whole picture, whether it is a triple negative or whether how is the rest of the disease. For example, if a patient already has a disease which is warranting as a neoadjuvant chemotherapy, then we would go ahead with neoadjuvant chemotherapy and do a repeat scan after the few cycles are completed, and then reassess them. If they have responded, that means they were metastatic. If they haven't responded and remain, I mean, the size hasn't decreased, or there's no change, then probably they were just infective, because chemotherapy wouldn't work on infective etiologies. That is one approach that I use. But if there is any, if there is a high suspicion, suppose that the size of the nodule is big, and suppose if the FDG uptake is not there, and if I feel the crunch to prove whether it is a metastasis or not, then probably we'll do guided biopsies. But most of the times, I think we put the whole picture in front of us, and there's no single answer. So yeah, I think this is what I would do. I err on the side of doing more generally speaking than erring on the side of less. For example, the case that I was just discussing, we did take a second opinion from another center, which we then discussed with the patient in a multidisciplinary tumor board, I mean with the medical oncologist, and then took the call that we will give neoadjuvant chemotherapy and do repeat scan and assess. And now we're actually going to do MRI after 4 cycles in this patient.
Thank you. Thank you.
Sounds good. Thank you. With this, we'll conclude our session. Thank you, Dr. Ramya, for your time and for this very interesting, comprehensive talk. We value your input on that. Thank you.
Thanks a lot for the opportunity to all the members, and I'll be very happy to have any feedback on my email also. And I'm very grateful for the opportunity. It was nice interacting with you all. Thank you.
Thank you.
Have a great weekend. Thanks. Bye.
Bye.